So congestive heart failure. What is failing? The heart muscle, which is called the myocardium. Very good. Now, what things can make your heart muscle die? That's wild. All right, so if you had a massive heart attack that left you with necrosis, and that necrosis turned into scar tissue, that is a possibility. That is true. All right, so if you fluid volume overload, so like let's say you were supposed to give, 100 ml to a patient by IV and you gave 1,000. Whoopsies. We overloaded them. Okay, so I'm going to give you the biggest risk factors and you're going to tell me why. Okay, there are two main risk factors for CHF. What are the two biggest ones? That is one, but hypertension is one of the biggest ones because you have high pressure blood flow going to the heart muscle. It's going to ruin your heart muscle, Abby. Okay, and being old. Those are your two biggest risk factors. Okay, now this is not the same as an MI, right? So even though like smoking, alcohol, like all of those like sedentary lifestyle, obesity, those are contributing factors. Those are not going to cause heart failure. Like something big would have to happen for your heart muscle to fail, right? Like you got massive myocarditis, right? Or you had a massive cardiomyopathy. What's cardiomyopathy? Heart muscle bad. Mad. So cardiomyopathy is an umbrella term for something. It's usually genetic, not always, but mostly something genetic. You had a bad genetic heart, right? And over time it caused severe weakening of the muscle. So it's just an umbrella term saying there's something that went wrong with your heart muscle, usually congenital or genetic. Do it? Okay. So acute heart failure, there's acute heart failure and there's chronic. Like acute heart failure means like it was something big bad happened one time and we done jacked up your heart. So what are the things that can happen with acute? Obviously an MI is one of them, right? And y'all said we gave too many fluids, right? That would be a big bad ugly event. Yes. You have acute myocarditis. That's big, bad, and ugly. That can immediately cause damage to the heart. Yeah? Okay. What about if the patient went into hypertensive crisis? That could cause an acute heart failure. Yeah? Okay. What is thyrotoxicosis? Thyroid storm, right? So if they have hyperthyroidism and also went into a thyroid storm, their blood pressure would be super high. So those are things that can cause an acute, like, damn, your heart just failed. Okay. Now there are things that over time, 20, 30, 40 years can cause your heart to eventually be like, I don't even want to pump no more. Like what? Hypertension, diabetes. Diabetes is a contributing factor, but think of things that are happening to your actual heart muscle, like coronary artery disease. Myocarditis would, well, it could be chronic too. I can agree with that. Like if you have sequelae from it or something, right? But think about like big things that could happen. What is cor pulmonale? All right, so you had a massive lung problem, your lungs filled with fluid like ARD, COPD, something, and it eventually caused which side of your heart to fail? The right side. Very good, very good. All right, congenital heart disease would be chronic, right? What's rheumatic fever? No. What is rheumatic fever? Y'all have heard of it?
Isn't it like the plague?
No, it is not the plague. It sounds scary because it used to kill a bunch of people back in the 1900s. That's because we didn't know that it was just a strep infection that went to the heart. That's it. And well, it ends up being an endocarditis, right? I didn't hear you say that. Oh, sorry. So rheumatic fever is just, it means that you had a strep throat or something, it went untreated, and then it went around your endocardium and you got an endocarditis. Now we treat it, no big deal, right? But it sounds scary like the plague, right? Because it killed a bunch of people before because we didn't have antibiotics and we didn't know what bacteria was. Okay. Oh, okay. And rheumatic, anytime you hear the word rheumatic, what does that mean? It's systemic inflammation everywhere. So these patients with rheumatic fever get joint pain. Their eyes get really red like that. So all rheumatic fever means is strep in the heart. Not that scary. We can fix it. Now they have to be on antibiotics till they're 18. But other than that, it's fine. It's no big deal. We can fix it. All right. Other things that can cause a chronic heart failure would be anything that's wrong with the valves. Remember, once you piss off the heart valves, they mad. Okay. All right. what are the two biggest risk factors for congestive heart failure? Chronic. I already told them to you. So age and hypertension. Then there are other contributing factors like diabetes, you've had an MI before, CAD, obesity, like all those other things that we know can be contributory. Smoking, sedentary lifestyle. What other patient population, though, can go into acute heart failure? Not because they're sick. Pregnancy, because you have double the blood volume in pregnancy. What? It's cardiomyopathy. They'll end up with a cardiomyopathy. Oh, eclampsia. Yeah, they can get that too. But pregnancy, even without preeclampsia or eclampsia, you just have double the blood volume. And if your heart area wasn't like super great, then pregnant people can go into heart failure. Okay. Hyperlipidemia, fluid volume overload. Y'all get these. Yes. Those are contributing factors. Okay. All right. What side of the heart usually fails first? Left, because the left is the hardest worker of the body, right? Okay. So how do you calculate cardiac output? Stroke volume times heart rate. Okay. So in heart failure, when the heart starts to fail, which part of that equation is off? The stroke volume is going to be off, because the stroke volume is how much blood comes out of the heart per beat. So if it's weak, it's going to go like this. So how do I fix my cardiac output if my stroke volume goes low? Increase heart rate. So the first thing that's going to happen is they're going to get tachycardia. Beat, 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 beat. Well, then what happens to the muscle? It gets enlarged first. Remember, it's going to get big. If y'all work out every single day for the next 2 weeks and you only do leg day, now your legs are going to be big at first, right? Because the muscle's kind of pissed off. But are you supposed to do an exercise every single day? Because what happens to your muscle? It will break down. So what happens first? They get tachycardia. Then the left side is going to get big. What is that called? It is cardiomegaly overall, but just the left side getting big is called, we already did it today, and y'all looked at me just like that. Left ventricular hypertrophy. It'll get big first, and then it'll be like, forget it, right? Yeah, I don't know what's going on with y'all today. I can't help you. I don't even know. Okay. So the left ventricle is then going to fail. Yes? Okay. And then that's heart failure. Yeah? Okay. The contractility is going to be really bad. What type of heart problem is this? This is a muscle, so it's a mechanical problem. Yes? Okay. So if the left side is going to fail first, well, first of all, what's the first sign and symptom of any heart failure? Fatigue. Okay, because I'm not getting enough blood flow or oxygen. So like, I feels tired, right? Y'all turn your papers over, please. Left-sided heart failure. Left is lung symptoms. So give me my lung symptoms. Okay. All right, so shortness of breath, which is called dyspnea. What else we got? Give me, literally, you could take any respiratory symptom and put it right here. Dyspnea, tachypnea. They're at risk of pulmonary edema for sure. You know, any respiratory, so just throw them out at me. Cyanosis, cough, hypoxia, all of these things are true. Okay, so we've got orthopnea. What's orthopnea? They can't breathe when they're laying down because all that fluid is on their chest. So what's a question that you ask to determine their degree of orthopnea? How many pillows do you sleep on at nighttime? Okay. Dyspnea, they've got rales, crackles, weakness, tachycardia, decreased SpO2. Y'all could have said any of these things. A cough, maybe? Oh, y'all gave me 2 symptoms. Why they got anemia? If they had anemia, it could lead to, I guess. Polycythemia. All right, they're going to get, now that fluid's just going to sit in the lungs, yes? Because they got crackles. So frequent pneumonias, nasty cough, left ventricular hypertrophy, tachypnea, wheezing. They may develop an S3 heart sound. What is that? It's like trying to, it's not a murmur. Murmur is turbulent blood flow. It's, okay, that's fine. It can be a gallop if that's what you want it to be. But what does it mean? Why? Why do they have an extra beat? There's so much fluid that it's like, I can't get it out with boom, boom. I got to go boom, 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 boom. Now, an S3 sound can be normal in elderly, right? So you need to determine whether it's from heart failure or not, okay? Activity intolerance, that's a given. Like they try to get up and move and they're like, okay, right? Okay. Huh? Okay, so left lung, left lungs. It's going to back up into the left atrium and then into the lungs. What is my red flag lung symptom? Pink frothy sputum. If they have pink frothy sputum, what does that tell me? Pulmonary edema. But pulmonary edema starts out with pulmonary hypertension. Yeah. Okay. I don't know. Give me just a minute. I haven't decided yet. Okay. So left is lung. Right is rest of the body, right? So if the right side starts to fail, it's going to back up into the superior and inferior vena cava and into the rest of the body. Yeah? So what signs will that give you? Ascites, JVD. No, because they're still like, they have some coming out the other side, huh? They might have a little bit of third spacing, so it might be a little swollen. Bounding pulses. There'll be pulses at +4. Cool. And then, huh? They may be a little bloated from the back of a fluid. Did y'all do this one? Okay. Anything else? Oh, if they have a headache, that probably means they're like stroking out or something. So they're going to have edema, JVD, bounding pulses, hepatomegaly, because doesn't the liver connect directly to the inferior vena cava? Now liver is all big and angry, so definitely you're going to have ascites, yeah? Bloating, when they're all like, they feel like eating. So anorexia. Now how much is coming out the front side, like the left side? How much cardiac output do they have coming out? Less. And the cardiac output goes right out the aorta, down the, and right to the, oh no. So will you have very much urine output? That is called oliguria, right? If the liver gets big, what else gets big? Yes. What else gets big? Spleen. So they're going to have hepatosplenomegaly. Okay. What is their weight going to do? Increase. Okay. Now I may develop a murmur because I have so much blood flow. What does a murmur mean? Turbulent blood flow. So you'll hear boom, boom. Oh, that's like a little beat, isn't it? Bush, boom, bush, boom. All right. They will have anasarca. What is anasarca? Edema everywhere. Okay. If one side fails, the other one's eventually going to fail. Okay. So we can do left-sided and right-sided symptoms, but like, it's eventually going to be both, right? Because even if the left backs up fluid into the lungs and the lungs are filled with fluid, and that's going to back up fluid into the right side. You understand? Okay, what's your big red flag for heart failure? Your big red flag for heart failure. If you could pick one symptom where you're like, damn, this is bad, I'm going to pick it. Oh my God, I can't help y'all no more. Pink frothy sputum. That is your big thing. Oh, I didn't hear you say anything. I didn't look at you at all. I'll go back and check out the video because I don't feel like I did. Unless I evil-eyed you or something. I don't know. I didn't mean to. I'm sorry. That's pulmonary edema. Yes. Yes. So like crackles, do we report that in CHF? No, because they always have crackles. But if they have crackles and fever, am I going to report that? Yes. If they have pink frothy sputum, will I? Yes. Okay. Oh my God. Could y'all give me just a moment, please? Okay. I just need a minute. Okay. Hold on. Okay. All right. Did I finish that whole page? You sure as hell did. Okay, let's move. All right, so how do we diagnose heart failure? Nope, turn your papers over. Okay, so we'll do a full history and physical exam because I need to find out, do you have any risk factors for heart failure? Like the two big ones, age and hypertension, or is you pregnant? Like, you know, I need to find out. All right, so I'll do a full history and physical. First thing I'm going to do is a chest x-ray because that's easy, simple, be done in a minute. What would I see on a chest x-ray that would tell me they had CHF? Cardiomegaly. So I would say a big giant heart. Yes? All right. If I did an EKG, would I find any abnormalities? It's not an electrical problem. The only thing that the EKG can pick up is left ventricular hypertrophy. It can see that. Okay. It's longer. Yeah. Because like you put the last lead here, but it can sense that there's electrical activity going past that because the bottom of your heart or the apex. Thank you. No, base. Apex. It's the apex. Nope, it's backwards. The heart is, but yeah, it's upside down. Okay, anyhow. I hate that. Oh, sure. It can say if they have an S3, but that's not considered a dysrhythmia. Like an elderly, it would just be normal. But yes, if it was an elderly client or if they had an S3, then yes, it could pick that up. Okay. But there's nothing like that's going to be like a STEMI or something that can tell me you have heart failure because it's not an electrical problem, right? Okay, but I can't do an echo. Now, what does an echocardiogram tell me? What am I looking at? I'm looking at it in real time, so I can see the valves opening. Is there regurgitation? Is blood going backwards where it shouldn't be going? Are the valves messed up, right? Is there endocarditis, myocarditis, pericarditis? I can see it all in real time. Yeah. Now on the echo, I definitely would see left ventricular hypertrophy. I probably will see some degree of valve dysfunction because if blood keeps going backwards, it's going to break your valves because your valves are only supposed to go like this, right? But if you break it backwards, that's it. You only have to break it one time, right? It's like a door. Yes, the door is only supposed to go one way. If you break through it, like that's it. It's gonna be floppy. Regurgitation is when we're like back up. Yeah. Yes. GERD of the heart. Okay. Whatever. So that's cool. All right. And then on the echo, we're gonna do an ejection fraction. What is an ejection fraction? So how much the percentage of blood that is pumped out of your heart per beat. Okay. What's a good ejection fraction? I mean, ideally we'd like it like 80, you know, but we consider it heart failure when it's less than 55. And that makes sense because at that point, like only half the blood is coming out of your heart per beat, right? Oh, boo, you was okay? Oh my God, that is so awful. I'm so sorry. You know why they call it that, right? Because it's attached to your humerus. I'll be here all day. Okay. All right. Okay, labs. What is the number one lab that we would draw for a heart failure? BNP. Okay, and what does BNP stand for? Brain natriuretic peptide. Greater than this number is like, you've got the heart failure. Sorry. 100. Get it rechecked. Okay. All right, then I'm going to draw LFTs. Why am I drawing LFTs for heart failure? See if the liver's mad, because liver mad could lead to heart failure, but also vice versa. Yes? Okay. And I'm going to draw BMP because I need to see is my electrolytes messed up, right? Because if we have fluid shifts and edema and that kind of thing, that can mess up your electrolytes. I'm going to draw cardiac enzymes. Why? Yeah, we can look and see if they're having an MI or if they've had a recent MI. Because what if a patient just comes in and is like, hey, last week I was feeling really bad. I was having some chest pain, but I ate a lot of wings. So I thought it was just indigestion. And now, like, I woke up this morning, my legs are real swollen. Then we're like, So we did a chest x-ray. We saw cardiomegaly, right? I'm like, oh no, your heart's big. So I ran my cardiac enzymes and my troponin is still elevated, but my CK, and then we're like, you had a heart attack last week and you did not know it, and it left you with heart failure because it did not get treated. Do you see what I mean? Okay. All right. So how am I going to treat heart failure? What do we have to do? Get rid of all this. How do you get rid of the fluid? Diuretics. What are my three options for diuretics? Furosemide, HCTZ, spironolactone. Okay. And all of those are going to mess with your electrolytes, right? Okay. HCTZ and furosemide do what to which electrolytes? Decrease your sodium, potassium, and chloride, the three ones that your kidneys are going to get rid of. Yes? But spironolactone increases your potassium because it is a, well, that is true too, but why is it a potassium sparing diuretic? What's its drug class? Yeah, blocker. Aldosterone blocker. Thank you for bailing us out. Yeah, we're having a test tomorrow, so I guess I know what y'all will be doing today. Cardiac drug. Oh, shit. Great. Okay. So there's that. All right. Diuretics. Okay. All right. Okay. So if a patient comes in acute heart failure, all right, you just got them wheeled onto your med surg unit, and they're like, here's a patient in an acute heart failure exacerbation. What's the first thing you're gonna do? Sit them upright is number one. I can always count on you to say that too, and you ruined it. But even with EKG, I don't even need an EKG on this patient. But it's mechanical, not electrical. Fight me, fight me. He came in diagnosed with acute heart failure. So that means he came through the ER and they're like, oh, using heart failure. And then they send him up to the unit and she's like, I don't trust the ER. Let me just tell for myself. Okay, so I'm going to sit him upright. Yes? Okay, the first thing you're going to do after that is listen to his lungs. Why? Huh? Well, I need to see if there's any fluid in there. I mean, yes, pulmonary edema, of course. Yes, that would be a concern. But more likely they have crackles, and I'm going to take their temperature. And if they have fever and crackles, then I'm like, the pneumonia led us here today, right? Because any infections are going to cause a CHF exacerbation. Yes? Cool. So I probably ought to put him on a pulse ox because, he's a little fluidy. Okay. And put oxygen only on if their SpO2 is less than 95%. Good. Huh? No, does across the board. Okay. Then yes, I'm gonna put him on a EKG just to because you wanted it real bad. Okay. I can give him some morphine if we're having a hard time, but CHF exacerbation shouldn't really hurt per se. It's just gonna vasodilate to the heart, right? Cool. Do you want to give them some IV fluids? They're in fluid volume overload. You could just murder. I understand. I was looking over here. Okay. So we're going to put them on fluid restriction. Yes. Okay. So we're like, not today because you have too much fluid. Okay. And then we're going to give them IV diuretics because I'm like, let's get rid of some of that fluid, right? Okay. Let's say you've had this patient in the hospital for a couple days and then you notice an increase in crackles. They're like real crackly. Their SpO2 is 92%, but there's no fever and their white blood cell count is 8. What do you think you're going to do? I forgot it already. Just kidding. Okay, so a patient comes in CHF exacerbation. They've been here for a couple of days. Okay, you notice an increased crackles, or you're like, dang, you are crackly today. And their SpO2 is 93%, but their temperature is normal and their white blood cell count is 8. It's fluid in there, so what do you need to?
Postural draining.
Okay, so we're just going to give him some Lasix, okay? So we would give him some diuretics to get rid of the fluid.
Well, they were already on diuretics.
It doesn't matter. You have to up it. You're going to give him Lasix. Anytime you get a test question where the fluid is in the lungs, we just need to get rid of the fluid. So how do you get rid of fluid? You give them some diuretics, okay? Got it? But if they say like, hey, the patient has increased crackles, their SpO2 is 92% and their temperature is 100.8, then I'm going to report that. We're going to think it's pneumonia. Diuretics will not get rid of pneumonia. No, they will not. So we would give some IV antibiotics. And so y'all need to know what to do with what assessment. Do you understand what I'm saying? Okay. So we did all the things for this patient. We want to prevent a pneumonia. How do you prevent a pneumonia in a CHF exacerbation? Turn, cough, deep breathe, incentive spirometer, Q2. Yes? What do you want to do with their legs? They are edematous. We're going to elevate the legs in this case to try to get rid. Now they're at high risk of pressure ulcers because anybody with edema is, because their skin is just sitting in water. Okay. Watch those pulses though. Yes, because I need to know if they're getting perfusion. I'm going to do some neuro checks. What am I looking for? Restlessness and anxiety could be our first sign of hypoxia, right? So let's watch it. Okay, so you're watching your patient and they're like, I have a cough and it's so annoying. And then they're like, oh, weird, it's pink. That's wild. Oh no. Should we report that immediately? What does this mean? That could be pulmonary edema. What are you going to treat that with? Oh, we lost it again. What is pulmonary edema? So we're going to give him some IV diuretics. This is simple, yes? All right. So in order to prevent pneumonia in this patient, you're going to make sure that they get yearly, which ones? Flu and pneumococcal, because those are the two most common respiratory shit, yes? All right. Let's say the patient is coming in with acute heart failure, but you're in the ICU. How would you change your plan of care? What's the first thing you do for this patient? Okay, so we're going to sit them upright. Okay, but if they're in ICU, that probably means we need to ventilate the patient because they can't maintain their own oxygen status, right? All right, so we're going to mechanically vent them. Yes, we'll give them some IV morphine to vasodilate. Oh, that's true too. We probably give some Lasix as well. We need 2 large bore IVs, or if we're like, hey, you're going to be here a while, we would start a central line. I mean, yes, you can start an ART line for blood pressure and ABGs, but a central line is how we give medications. That is correct. Are y'all okay? Are we good? Okay. All right. So you did all of that. I need to know, though, their actual internal pressures in the heart. Well, what I put in. Yeah. It's a Swan-Ganz catheter. It's a pulmonary artery catheter. Okay. Yeah, that's going to go directly into their pulmonary artery and monitor their internal pressures. Because when they're in ICU, I need actual pressures. The blood pressure ain't going to do nothing for me. Pulmonary artery catheter. Okay. All right. And then for heart failure, what's a code drug that I use for heart failure? Number one heart drug. Number one code drug we use for heart failure exacerbation. Dobutamine. Number two would be dopamine. Good, good. Okay. If things go really bad and this heart is not doing well, then we may need to take some pulmonary artery catheter. Okay. So we may need a pacemaker if they can't maintain their own heart rate, right? Like if they develop a heart block, that could be common. If their left ventricle is like, I ain't gonna work no more. I am tired, I am hypertrophied, and I am just done. Well, if their left ventricle isn't pumping, then they don't have any cardiac output. So we're gonna have to do an LVAD. What's an LVAD? Left ventricular assist device. It is a machine that we put in that actually will pump the left side of their heart for them. Do not cut the wires. R.I.P. Denny. Yes. Okay. Or at some point we're gonna have to say like, hey, your heart is not doing well. You're just gonna need a full-on out transplant. Okay. All right. As far as teaching, let's say we healed this patient and he is gonna go home. BMI less than 25. So we would like for them to exercise. How much do you want them to exercise with heart failure? 30 minutes a day, 5 days a week. That's never gonna change. Okay. Cool. All right. What kind of diet? Low sodium, high potassium, unless they're on spironolactone or ACE inhibitors. Can they have salt substitutes? Yes, unless they're on ACE inhibitors or spironolactone. Salt substitutes are good because they're made of potassium, and that's what I want. Yes? Okay. Do you want them to drink a lot of fluids? So even at home, they're going to have to go on fluid restriction. Yes? Usually they're a little nicer with heart failure than they are with kidney failure. They'll give you like 1 liter a day or so, which is kind of nice. All right. Are we going to send them to rehab? Oh, yes. Okay. Cardiac rehabilitation, you will always choose that. And they have got to have home health come out and meet them to make sure that their home environment is safe for them. Okay. Big things to report. I'm going to give you a symptom. You're going to tell me what it is and why you're going to report it. Pink frothy sputum. Pulmonary edema, which means they are drowning in their own fluid. We should report that. Okay. Fever. Pneumonia or some kind of infection. Most commonly, it's going to be pneumonia. Sudden weight gain. Heart failure exacerbation. That is a giant red flag. They should report if they gain more than 3 pounds in 2 days or 5 pounds in a week. So a patient needs to take their weight every single day at home at the same time with the same amount of clothing, okay? And then report that, okay? Increased edema. What could that mean? Exacerbation, heart failure exacerbation. Restlessness and anxiety. That's the first signs of hypoxia. Change in mental status. Your cardiac output is not enough. You're not getting perfusion to the brain. Increased dyspnea. That could be pneumonia. That could be pulmonary edema. Regardless, it's worsening of heart failure. Okay. Do you understand congestive heart failure? Cool.